So it's my honor to introduce Dr. Devin McCaslin, who's joining us today from the University of Michigan, where I first met him. But he has a PhD from Ohio State and has been instrumental in kind of leading several vestibular departments. So after he finished his training, he worked both at Henry Ford Hospital, Vanderbilt, and Mayo Clinic. And then we were very fortunate that he came to join us at Michigan a few years ago. So he has a lot of expertise in the vestibular system and was an excellent addition to our department. And I'm very excited to hear his presentation this morning. So thank you so much for taking the time out of your day to join us.
Thanks, Susan. Good to see you. Let's see. Well, so should I share my screen, or did you want to? Are you gonna do the CME slide, or?
I did it quickly, and that's all we have to do. Yep,
all right.
Good
Great.
to go.
I will share then. Okay. Well, thank you. I mean, it's an honor to be able to give the talk to you this morning. I know it's early there. This is right in a sweet spot for me. So it's Eastern time zone, giving the talk to your Pacific. So what I'm going to do is talk a little bit about as Susan mentioned, I've been in the interested in the vestibular system for 20 plus years, I guess now, and it's the age-old challenge of ENT always being seen as, everything dizzy and everybody being sent to us. And, it's, as a run vestibular labs, both like at Vanderbilt and Mayo and here, we have the same issues going on is these poor patients wander around the healthcare system and, until they finally stumble on somebody that knows what they have or they don't. And, they cost enormous resources. We'll talk a little bit about that. And so I'm going to talk a little bit about my experience. I picked up most of this at Mayo Clinic. Is where I really became interested in this for about 4 years, is using some of these, sort of big data, machine learning techniques, predictive modeling, or building models to maybe do a little better at getting dizzy patients where they need to go. I'll talk a little bit about, I'm not necessarily trying to diagnose. I was just trying to actually get the right patient to the right provider. Could I even do that? And so give you a little background on what we did and what it worked on, and then some of the things I'm developing some, sort of doing some other things with this as well. So talk a little bit about that. So just my experience. And again, this represents the work of a lot of people, not just myself, as you'll see as we go through. So just to get the disclosure out of the way, I have commercial support from Sonova and Interacoustics. And I have some NIH money, state of Michigan money. And then the University of Michigan actually just funded me to build a similar system as we're going to talk about today for internal for us. So I am now embarking on building one, developing one with our precision health team and our ambulatory care group to how can we do better with dizzy patients here using some of these, again, machine learning models and predictive modeling. So excited to build one that's specific to us here at Michigan. So I'm sort of a big fan of the biodesign. I don't know, it's a Stanford approach to, sort of how do you, develop a health, you have unmet need in healthcare, and it takes you all the way from development to implementation to with and so I sort of followed that procedure to some degree, so with the process to development, what we did to get to this point was we had the problem, and the problem, of course, is that during dizziness is the third most common complaint among primary care physicians, right? And is in our system here, and Mayo was a little different in that it really didn't have a primary. It was a little different system that didn't have a primary care referral system. It was you had to apply pretty much to get in. But here, we have primary care feeding ENT and otolaryngology, and so what happens is we end up being the first line of for subspecialty referral for dizzy patients and all of them. And so yesterday, for example, I was in clinic all yesterday and I saw 3 patients, none of which had any inner ear balance issues. but all had psychiatric comorbidities or issues such as that. And, we can talk and we can help them and get them to the right place. But they were co-scheduled with our neurotology group, right? So there's 3 neurotology appointments that are not going to result in any surgical issues, but are going to eat up an enormous amount of time, and they like to talk, as all of us know on this call, on this presentation. So it's a non-specific symptom, right? It falls between the cracks. It can be cardiovascular, it can be psychiatric, it can be a whole host of issues. And what we know is that we often give them the DHI. I've done enough DHI studies in my life to now know that the DHI doesn't really have anything to do with laboratory results. And in fact, we just published a paper because I was getting pretty tired of, what are we measuring with the DHI? We're giving everybody the DHI. What are we at? We're not measuring handicap. It's self-perceived handicap, and the way people self-perceive it is we found that most of these people that would have psychiatric comorbidities would score very high, and people that just had structural issues would score pretty low. And so we're actually measuring, with the DHI score, measuring, their self-perceived handicap, which is pretty much modulated by psychiatric comorbidity. And so, well, that's valuable. It's really hard to use the DHI to say, hey, you should see a surgeon, or no, you shouldn't. It's estimated about 69 million Americans have experienced symptoms of a vestibular disorder. About 10.4 million have chronic dizziness. These are really the ones that eat up our healthcare dollars in terms of those with dizziness. Really the way we broke it up was there are people with acute vertigo, there are people with positional vertigo like BPPV that we can take care of pretty quickly at the primary care level. There's episodic vertigo, which is a little more complicated because that can be Meniere's, that can be vestibular migraine. And then there are those that come with chronic dizziness that have it every day. Again, I saw 2 of those yesterday where they are, one was in a wheelchair. And can really, some of these functional disorders, lead to this. But as we know, there's a significant shortage of those that really understand dizziness and can manage and want to treat them, or even want to treat them. And so what we've ended up having is poor patient outcomes. And something we haven't really done well in the vestibular domain, at least, anywhere I've worked, is actually track outcomes. Now, in hearing, we do that in spades, like cochlear implants or hearing aids. We really understand the outcomes really well. With vestibular issues or dizziness issues, we, if they don't come back, that's like a successful patient, right? And it's not that they got better, it's just they went somewhere else in most cases. And so, the question is, how do we get our head around this? How do we get these poor patients to the right people that can help them for their problem? It's not always going to be our otologists or our neurotologists. Well, they can be infinitely helpful. I don't know that, with the metrics that we have here, and that's part of the reason I got funded here to build another one of these is it's, clinic conversion ratio, it's filling your OR schedules. There are a lot of factors and metrics now that healthcare has become so business. When they looked at, I think we pulled 6 months of data on our dizzy patients, and they came to me and said, we had zero that resulted in a surgery. And, the administrators asked, why are they seeing, why are we seeing these patients? And, that's some of the pressures that we see, the financial pressures, and that sort of drove me to see if we could do a little better with some of these new techniques that have become available recently. So we actually call it the Martini Project. Neil Shepard, when I moved to Mayo Clinic from Vanderbilt, what he would do is he would triage, and everybody's got some form of triage. We have a form of triage here. Everybody sends all their paperwork, and we go through and who do they need and what tests do they need, and usually it's clinicians doing that. It's a manual process in most cases, and it's not like we haven't used intelligent algorithms before. I think the Finnish have been using it, the Finns have been using it since the 80s when machine learning was first sort of bandied about. But these intelligent algorithms, they've never really been adopted. And, paper and pencil is fine, but, one of the keys is that it really has to be embedded in our medical record. If I've learned anything, you need an HL7, and if it embeds in our medical record, then people will use it. And if they don't, then they're not going to use it. And but people have used algorithms for decades in terms of dizziness, and you have the electronic ones, but if you get in the wrong arm, maybe you don't get it, or it only gives you one diagnosis. It's not really accounting for the fact that the way we would look at it is there are structural issues. So something wrong with the physiology. You've got homeostatic failure in the ear, and you got Meniere's disease, but maybe you can also have psychiatric issues, and maybe you can have functional disorders. And so it really became a approach of looking at the structural disorders, the functional disorders, and the psychiatric disorders. And it sort of looks like, and I don't know that I have it in this talk, but it's a Venn diagram, and they all overlay, and they come to you and they present to you. And it seems like it's all over the place, but it's really this amalgamation of some combination of those three classes of disorders that are being presented, and they don't really have the medical terminology to make it clear. They certainly get better at describing what's going on as they see more and more medical providers. They start to learn the difference between vertigo and dizziness, but it's really difficult for them to sort of disentangle what's what and present it in a clear way. And so I think that's why some of these algorithms, a lot of these algorithms have really been predicated on trying to get a diagnosis. You've got Meniere's disease, and can we get Meniere's disease? Well, it's not hard to get Meniere's disease, right? I mean, it's you got 4 symptoms. That you've got the ear is not happy, but you have no idea why the ear is not happy, right? Is it viral? Is it autoimmune? Is it is something hydropic, or so it's the Meniere's disease thing isn't all that helpful either in a lot of these cases. So the concept was develop and implement a learning algorithm. So taking what's done, like Neil Shepard and I did. Neil would sit down, and he would go in on the weekends, and he would go through all these files, and he would read through all their reports and all the results that they had and decide what combination of physicians would be best suited to take care of their dizziness. And my wife was not going to let me go in on the weekends and go through tons of folders, and that's just not going to end up well for me. And so we went to actually a martini bar. Like I said, it's called the Martini Project. And actually I said, is there a way that we could build a learning algorithm? You sit and you do this, and you're using an algorithm in your head, but could we actually come up with a learning algorithm using AI techniques, predictive modeling, to maybe have them fill out the questionnaire? It's 160 questions. No doubt it's a long questionnaire, and we're trying to make a shorter one. But could we do that and automate all of this process? Because we were paying clinicians all to do this. We would spend time for audiologists out of every clinic week. I think everybody got a half a day where they weren't seeing patients, but we're actually triaging. And so we were, and everybody wasn't doing it quite the same way. Everybody had a little different algorithm about who was going to get where. And so again, the idea came up with, could we sort of standardize this using these techniques? And could we develop a system that could track outcomes and then learn? Could we get better at it? With the idea of leveraging, if you get millions of patients and you start to see these patterns, then, maybe we can do better. And so really the 3 tenets of everything we were trying to do was fastest time to diagnosis. Could we get a diagnosis? Again, we weren't trying to diagnose. That I think gets you in a lot of trouble on the front end. So it was literally, could we just get them to the right physician to give them a diagnosis? Get them in front of the right person for them. If they have a headache, could they should probably, could they be seeing a neurologist? If they've got psychiatric comorbidities, could we get them in front of a mental health provider? Could we do it with the least cost? How could we do it without having to, have them see 50 different providers? Could we get them right to the right place at the right time? And then, we had, if we could do that, then we could, see what we treated them with, and then we could start to maybe learn what our best outcomes could be. And so how could we then get the best outcomes? So it's sort of around these 3 tenets: fast time to diagnosis, the least cost, and how could we get the best outcomes? That was sort of the 3 simple things we were trying to do. So again, here we are. I guess I do have the Venn diagram in here. So, you know, I was lucky in that Mayo Clinic had you know, they've really invested heavily on the AI side of things. So I wrote a grant, got an internal grant at Mayo Clinic saying, you know, I want to do this. I could, you know, the idea being that I could free up surgical spaces in neurotology and otology. If we could maybe, you know, get some of these dizzy patients that out of their clinics into people that could really, you know, that were more maybe appropriate in their cases. And so I got funding. And again, we were looking at, again, from this perspective of looking at structural disorders, functional disorders, and psychiatric or psychological disorders. And so our core specialists in the group that helped build this was otolaryngology. So you know, Matt Carlson and Colin Driscoll and Brian Neff, they were really our, you know, sort of our otolaryngology team. Neurology, we had Scott Eggers. He's an otoneurologist, again, trained at Hopkins and has been at Mayo for quite some time. Psychiatry, we were very lucky in that we had Jeff Staub and others there. Audiology is myself and Neil Shepard, and then we had a few physical therapists on the team. And this really composed the core team. Now, it wasn't to say that there weren't things that fell outside these core, you know, issues, but at least this was the thought group that was putting everything together and helping design the model to get people where they needed to go. And so here we are, right? So this is kind of the core team: psychiatry, audiology, neurology, and otolaryngology. So what the framework that we built initially is the way that the system would work is Neil Shepard had developed this questionnaire at his time at Penn. It's like I'm following around. He was at Michigan, he was at Henry Ford. I didn't go to Penn. He was at Penn, Nebraska, but he had developed this questionnaire that eventually he you know, brought with him to Mayo Clinic. That, again, like I mentioned, was 160 questions, and would cover all the different forms of dizziness and associated symptoms and timing and triggers and you know, all of the issues that you know, we would normally take during a case history. A pretty extensive questionnaire, and then you would, you know, sort of take those questions and those responses, and then, you know, try to decide who you need the best. But there are pretty much four main arms, and so what they would do is they would get the symptom questionnaire, and what we would do is send that to them before they came in. They would send all of their results in that they had had previous testing, and then they would get audiometry, and they would get vestibular lab testing. At that point, there were four primary arms here. So there's otolaryngology, and what the model we were building was really pre-scheduling, automated scheduling. That's what we were looking at. Okay, so it would be, they would fill this out, and what it would do is it would predict what their schedule should be when they would fly into Mayo Clinic. And so, you know, it wouldn't be like, hey, we're going to ENT, but now we got to add somebody on. It would be like, okay, here's your schedule for time for your visit. And so otolaryngology, we broke that between medical otolaryngology and neurotology. Psychiatry, we had vestibular psychiatry and we had general psychiatry. So if you had a host of these, you know, like persistent postural perceptual dizziness, something pretty specific, or you just had general anxiety, vestibular psychiatry really centered around sort of the functional dizziness disorders. Whereas general psychiatry, if you didn't have anything with like 3PD or maladaptive, then what, you know, you only had general anxiety or depression, we would kick, you know, to general psychiatry. Physical therapy, neurology, we had otoneurology, which was pretty tough because, again, trying to identify central disorders, cerebellar disorders through a questionnaire is you know, and I think there's some work we can do there. And that was probably our toughest. I'm not convinced we can't do it. But you know, there's some learning to do there. But headache neurology, right? So headache specialists, if you've got refractory migraines, you've got treatment-resistant migraines, then we would send them to headache neurology. If they had pretty much vanilla migraines, hadn't tried treatment yet, then maybe you go to general neurology. So again, these decisions were decided by, you know, neurology had representation on us when we were building the model. Each individual group had, you know, a say in what, you know, what they were going to do and who they should be referred to. And so this was the general structure. So could we drop in whatever combination based on the patients coming in? Could we get them to the right right physician, right combination. And so there would be some that had 3 or 4 appointments, or some that had superior canal dehiscence. That's all they had, and so they would see our neurologist. And so that was kind of the idea behind it. So as I show sort of here, what we've got is in the past, the patient would call the balance clinic. We would send them a questionnaire in the mail. They would send all of their stuff back. Again, this is what would show up. And that's actually kind of that's probably a moderate one, the one in the middle. That's what would come back, because we didn't ask them to send, only send the results that are important to us, because, they don't know what that is, right? So we just said, send your current medical history that is related to your dizziness problem, and that would show up. And then we would I'm saying we would pay clinicians to go through all those files, 90% of which were like completely unhelpful. And then we would go through and look at the questionnaire. And we found that pretty much driving who we wanted people to see was the questionnaire. In some cases, some of the vestibular testing would help, but as we all know, there's, some places that do really good vestibular testing, like your groups, and then some places that maybe don't do such a great job. And so it's tough to tell, was the vestibular assessment, is it real? Is it not real? You're seeing a unilateral weakness with air calorics. You're like, really? I don't know. Maybe, maybe not. Who knows? But we would redo that to sort of, when they came, to sort of make sure that we knew what was what. And then we would, we would fill out a form, and we would give it to the scheduler, and then they would call and schedule the appointments for them to come in. So the future was, what we were trying to build is we send them a questionnaire. We didn't want the external files. They fill it out online. What happens is it pushes back automatically. The system goes in, and I'll show you the template. And what it would do is the model would be analyzed. It would give use the predictive modeling to say, hey, these are the schedule that you should have based on the responses to the questionnaires. And then what would happen is that would immediately get pushed to the scheduler. So what happens is the clinicians were completely taken out of it at that point. Now, taken out of it, there's heavy supervision, and we can talk about those things. We didn't just let it. I have a 17-year-old son, makes terrible decisions all the time, has horrible judgment. And so the models have to be supervised. It's sort of like a teenager. You kind of got to make sure it's not doing crazy things. And we would supervise it, heavy supervision, and then it gets to where, you say, okay, I think it's doing what it should be doing. And so the idea was to essentially get the clinicians out of the mix and free them up to see patients, right? So what we did is development of the model. So the grant that I had been awarded at Mayo allowed me to go to they have a whole group of AI projects, and you go and you pitch your AI project, and if they decide that they like it, then they will give you the team that you need if you can fund it. And so we had model creators and data scientists. And so these people would show up to all of our meetings when we were building the model. So we had all the clinicians in the room, but we also had sitting there the project manager, as well as the model creators and the data scientists. We also had input from the schedulers, again, clinicians, and then sampling patients for what would be the ease of use. And so the Center for Science of Healthcare Delivery is where, at least the Mayo Clinic, where all of the AI experts live. And the idea was then to build, the first one was, could we get the right patient in front of the right physicians? Just help, again, it's more of a decision support issue. We're not trying to diagnose anything here. So prediction of the schedule was the first group. But then, and something I'm working on right now is, I have some grant funding for it, is what are the most appropriate diagnostic tests based on a patient's symptoms, right? So right now what I do is in every clinic I've ever worked at, you get a 2-hour exam, and you get every test we do. And, do you need every test? I don't know that you need every test. If you have a 35-year-old woman and she has normal imaging, and she lost all her hearing in one ear, and she's got an abnormal V hit on the left side, you kind of know what the answer is, right? Do you need to do all the VEMP tests? I mean, is that going to change any rotary chair? I mean, is that going to change what? I mean, I don't know. I mean, in some cases, people can argue either way. I think I could probably argue it from both sides, but I think the question needs to be answered. do you need to do all of those tests? And when you know the answer and you can then, push to the therapist or the physician for medical treatment, what is that like, rather than just doing everything on everybody? Again, audiology has a little different issue because we're only seen as diagnostic by Medicare. And so we bill by codes and we practice as we are paid. So there's some of that going on in the background, but, I'm trying, I'm trying to understand, if I've got a certain case history, can I get to the answer pretty quick? Allows me, I've got access issues right now. It's about 6-7 months to get in. And so I think I can do better if I can not have to do everything on everybody. Some you do. So prediction, the most likely source of the patient's complaints. Again, that gets in the diagnosis. I don't, that's a tricky business, as we all know. But I think that what will happen is like we were talking about Meniere's disease, right? Why is the ear unhappy? There can be a lot of reasons. You're getting those 4 symptoms. Maybe when we have, tens of thousands, you start to see patterns and responses to allergy issues or things such as that. Or, we all know people that, if they go over 1,000 milligrams of sodium, they're going to get an attack. Some people, sodium doesn't make a bit of difference, right? And so what is the difference between those people? And I think that big data can help us in that. I think we've got a ways to go, but also generate standardized reports, little things, sort of operational issues, and then be able to conform to different clinics, right? So what happens is, at Mayo Clinic, it's nice because you have a psychiatrist that's interested in vestibular function. Well, he's the only one in the country, so not everybody has that. So in my healthcare system here at Michigan, we don't have someone like that. So who would be willing to see these patients? And so then the model can, sort of adapt itself to say, we develop these issues, these groupings called competencies. So you got somebody with, functional dizziness. Who's going to see them? You got to decide in your system who's going to see them, because that's who they're going to get pushed to. And so we need to do that as well. So it's complicated, right? But I think, again, the first one, the most basic one, was could we just literally get them in front of the right physician with automating it and get all the clinicians freed up and get them our neurotology schedule. So let's see, where am I here? Okay. Which way am I going here? Okay. Oh, wait a minute. I'm sorry. Okay. So implementation was, so again, like I talked about, the questionnaire really focused in on timing issues, triggers. Those are the high value questions that we're going to ask patients. Accompanying symptoms, are helpful, and absolutely no question about that, but can be misleading in a lot of ways. And symptom quality, I think some of that work done by Newman Toker at Hopkins, where patients are just absolutely horrible at, symptoms. They get, like I say, you see them get better over time, talking about vertigo or, the difference between external, internal vertigo immediately, but then they start to figure it out. And, but symptoms are not great. And I think we focus a lot on symptoms, but, we picked up all of that in the questionnaire that we would send them. And then what the system would go in is it would go in and it would analyze the relevant features for the algorithm. And so this is sort of what the algorithm would see. They would fill out all of these questions, and what you would get is these features and the symptoms. What they stand for different things, like U is unsteadiness, or D is dizziness, vertigo, 24/7 being chronic. Do they have spells? Do they have head related? Do they have visual motion issues? Visual complexity, looking at some of these functional. But anyway, we went through and sort of broke this all up in all different ways, the things that maybe, timing occurs, but also what exacerbates their symptoms. And the system would go through and sort of classify these in order to sort of break these down and, sort of say, remember back to that big Venn diagram, is it structural? And if it's structural, then who should be seeing them? And we counted migraine as a structural issue. Is it psychiatric or is it functional? And so then what it would do is it would push to the scheduler who was going to get the schedule. So it would talk about audiology. Yes, it would go through medical ENT, otology, neurology, what type. And so literally this would go, this is the response that would get pushed to the schedulers. And so they would then automate and schedule. Now, we were watching this. We were heavily supervising. So we wouldn't, it would give the response, but before I went to the scheduler, we would go through and we were verifying either way. Let me see, did I miss the yeah, so it kind of skipped here. So when we went through and we looked, I'm sorry, I somehow skipped these slides as I was going, but this is kind of how we broke it out. So remember, I showed you the little framework that each of the different disciplines. And when we went through pre-post, so what we would do is we would sit in order to train the algorithm. You have to train the algorithm, and then you have to validate the algorithm. And so what we did is we all sat in a room every Tuesday night. It took about 3 years. I believe people were done with about after that. But we would all sit, and again, all the representatives that I showed you from all the different disciplines, and with the model builders and the project manager, and we would go through Epic. So we would take patients that had gone through the multidisciplinary clinic, and we would pull up the Epic, and we would go through their final diagnoses and look at who they had seen. And then what we would do is we would say, this is the response, this is the schedule that we gave them, but this is the schedule they should have had with their final diagnosis. And so that's how we trained the models. We went through our medical record with the group. It was an N-1 grouping, meaning that, we could have dissent from one of the people and still let it go through. And so what we saw is that the big one was that surgical ENT dropped a lot. And of course, when you move them out of surgical ENT, they go somewhere else. And a lot of those went to psychiatry and neurology. But you could compare what, the first set of analyses were like, who did we have? We went through with the expert panel and said, who should they have had? And then we put this together. So it was pre-algorithm and then post-algorithm. And so then we built this. And so we used Qualtrics on the front end. So what would happen is it would get pushed. They would fill out the questionnaire. It would come in. And then what would happen is the model broker would pull it, would apply the algorithm to it, to their answers or questions, and then it would push it. Like I said, it would give us the classifiers, and then it would push it to the scheduler while it's being supervised. This is just sort of what the questionnaire looked like on Qualtrics. It's very simple, and it would go through it each had sections, and it wouldn't let you finish until you were done. And we went through that, and I showed you that. So then when we had it, so we had done it, we had trained it, we had validated it. Again, it took about 3.5 years, I think, even to get it validated in operation in Qualtrics. And it was working very well, and it had automated this, and people seemed really pleased with it. And so then again, we went and we said, well, this is pretty handy. And of course, the Mayo Clinic has a business arm, and if you have something that you'd say you'd like to scale, they will have an attorney in your office in 2 seconds. And Cologuard is the best example of that, or the Vanacream, all these things that you. What's interesting about that is you never see Mayo Clinic's name on them. It's all, but those are all Mayo Clinic products that they push out. Didn't realize that one. So the idea was then to identify strategic partners, see if you could scale this, and did we have something, and then you have to look at regulatory strategy. And again, if you're the idea was to stay away from diagnosing things online, and that makes the FDA real uncomfortable. And we had a group of people that we worked with, and so Jeff Staub and Mans Magnuson, Michael Karlberg are from Sweden, 2 neurologists, Neil, Scott, Colin Driscoll was a big part of this. So what happens is we found a partner, and it was a Danish group. And what they did is they decided to take this and commercialize it and make it a little more, a little more appealing on the front end. Qualtrics is good for a first sort of iteration, but then how could we do that? And so again, this is what we have here is we have the full vestibular report, and what we used were called symptom clusters. And again, not getting into the diagnosis component of it, but saying, you know what, all these people say they have oral fullness, episodic dizziness, vertigo, fluctuating hearing loss, and all the things that sort of go along with Meniere's disease. And so you would have, you could identify those, or if you had superior canal dehiscence, or if you had migraine. What was the nice thing about this is that it would overlay them, right? So it would, it would say, well, they've got all the clusters of Meniere's disease, but they've got all the clusters of migraine as well. In fact, we call them micro-Meniere's, where they got everything in both. So symptom clusters was not so much as diagnosis, but sort of trying to understand, trying to learn from, like, how much difference is there in the patients that have Meniere's disease. We know they have a lot of different comorbidities and things such as that. So it was sort of a first sort of initial path to say, can we start to get our head around, all these overlapping issues, and maybe then, tease them apart once we have that data. Examination recommendations, what we would recommend, who they would see, and then referral recommendations, right? And so, again, when I get back to it, I say, the fastest time to diagnosis, and again, one of the interests of mine is how much testing do you need, and what testing do you need for which groups and which patients. So if you have BPPV and it's all you pretty much have, you probably don't need a 2-hour vestibular exam. Again, people could argue with me either way, and I could probably argue it either way, but I think, if that's all you got, a cannula repositioning procedure is pretty good, and you're out, and you can get your next patient in rather than spending 2 hours and then billing our insurance. And so again, these get into financial issues, which that's a whole nother discussion for another day. But this is what it gives us. So model recommendation, you can see flagged symptoms, positional vertigo symptoms, recent vestibular migraine symptoms. It would prioritize, Dix-Hallpike first, then other ones that could go down. Again, this is what I'm very interested in, is how much of this do you need? What do you need? What ones have value? And in terms of getting us either the rehabilitative or medical treatment that patient needs. And then again, what you'd like to do is really have an international database, right? So I think, this is leveraged on the idea that you're going to get more and more data. And that's the beauty of it. It keeps accumulating data. And the clusters get tighter. And then the beauty of it is really tracking the outcomes. And so, again, like I said, I think the weakness in, I learned a lot building this one. So I'm actually in the process of building a couple more with different approaches, doing the same sort of thing but sort of embedding them in a medical record, so that it leverages all the medical record not that the diagnoses are always right in the medical record, boy, we all know that, but trying to leverage what we can out of the medical record, get it all into one place, and can that help us do a little better with these patients, both in terms of treatment and things such as that. Quicker patient care and more time for additional patients, right? Access is my biggest issue, as it probably is for most people on this call. So the symptom clusters, the first ones we got, and what I think the beauty of this is that, these are things that we've made up, right? So we patients come and they always give us these symptoms, and we've made this up, but I bet there are some, subtleties in these, like Meniere's symptoms and things such as that will start to manifest. So, you get 1 million people, there's probably going to be a lot more, disorders than we think there are. There's going to be a lot, it's going to be a lot more granular. And so, you're actually using the data to inform us. That's a weird set of symptom clusters, but 10,000 people have it and they respond to that. That's pretty powerful, right? Rather than saying, you've got this and now you need this, so I think that what's kind of cool is, and I think it's going to change a lot in healthcare is that we're going to learn a lot from these data symptom clusters and these patterns that we're going to see over time. But we started with the ones that we all understand. We all understand these, and they make sense, and it's what we've used for years, and it's a good starting point. But again, as data starts to accumulate in these, I think we're going to start to see a lot more, and there's probably a lot more strange, a lot more disorders out there than we actually think, or we can probably be a little better with treatment. So the workflow, right? The patient calls in, they can fill it out on their phone. That's sort of the key to all of this. And then, following the questions, you go through and they can fill it out on their phone. That was sort of the key. And they put their information in. All of this could be done on your phone, right? And that's what they found is that new generations really want this kind of healthcare. They want to have access through, my 15-year-old daughter, she door dashes everything. Everything is online. And I think healthcare is now getting to a point where, we can do maybe a lot of that online. It's not all going to be online, but I mean, it's convenience, right? And it's just what newer generations really like the idea of having access to everything, online and just being a little more efficient. And again, multiple, algorithms. It's starting to stack these algorithms, based on your test equipment, your in-house specialization, specialists in the area. Can you connect people in an area, right? Maybe you don't have every provider at your institution, but there are providers in the area. So then you can start to connect people. And I think Epic Care Everywhere, maybe you can leverage some of that. Those are some things we're looking into now. I've just run into some roadblocks because anytime you want to go into the medical record in your institution, people get, and they should be, they get a little bit paranoid. And so that sort of slowed me down. I have to explain and get priority, and you need builders, and, not anybody can be a builder in Epic, right? You got to they're like rare as hen's teeth. And so, there are resource issues as we try to build these things. And then, a clear output for the clinician, symptom clusters, recommendations. And I think what'll be really exciting is as we start to learn, about treatment. I think that's something, how do people respond with the different symptom clusters, who responded well to what? And again, it's not taking in any way the physician out of the mix. It's literally just getting people to the right point faster. And the grant that I wrote here really was predicated around maybe we could have our primary care colleagues, use some of this data to at least try a first pass. And if it didn't, if treatment didn't work well and the outcomes, and again, I'm sort of picky about the outcomes. I'm not sure we have a great dizziness outcome. I know Barony is working on, the Barony Society is trying to put one together right now. That's more of a functional. I just, after the DHI, I've just sort of lost hope in all of these dizziness outcomes. I think we almost need customized outcomes. That's, I think, going to be the next thing I'd like to look at, or, I think where what happens is you really, what is success for that patient? And then it develops, I think you can use some of these machine learning techniques to say, well, here's an outcome, and this is what's important for you to be successful. And, so, it's customized or personalized to them. I think maybe we're looking at it the wrong way, but it's not like you don't have enough work. So it's, but I think that may help us do a little better on the outcome side. But the point being, if primary care doesn't get to the significant outcome, whatever you decide that, that is, then maybe you push them to subspecialty, right? Maybe they go to, psychiatry or headache neurology or neurology or, whatever it needs to be. And I think patient education, I think we would probably all agree that if these patients are, a lot of times they're just informed about what's going on and understand there's nothing that can be done surgically or medically, but, here's what's going on with you, like in a case of a functional disorder, like 3PD or maldebarment, and you work with your physical therapist. And, I think education can we build, we can't all sit and talk to them for an hour and a half, as many as they would like, but can we do better with online resources and getting them that information in a way that, they can utilize? It's different for everybody, I get that. But, I feel like these people just need good education in terms of what's going on and why they have this, and sort of taking their symptom clusters and building a almost like a video set around what their symptom clusters came out to sort of give them a customized or individualized educational program. And so that's what I think the power of this is. Once you have this data, you can start to then build off of it in all different ways: education, treatment, outcomes. So it's exciting. And then clinic optimization, right? So, Mayo Clinic, in order to get the grant, what I had to do is I had to show proof of concept. Did it work, right? So they'd stick it in front of clinical practice committee for this committee, and they had to say, here's this project we funded, and you got to tell us how you did. And so, pre-algorithm, 33% of patients, post-algorithm, only 18% of our dizzy patients were going to neurotology. Again, it was a pilot study, but, saved 90 appointments for that little test case in that timeline. So again, we were getting them out of our neurotologist schedule. We looked at number of appointments, but really what they did is these are the project metric descriptions that I had to meet. Algorithm accuracy. And the thing is, the algorithm is not going to do better than the people at first that did it, right? We trained it to do, it's only doing what we wanted it to do. And I think that's what people lose sight of, is that they're like, well, it's not any better than you doing it. Well, it's not, because we trained it. And so it's doing exactly what we told it to do. It's just math, and we designed math around it. Where it becomes handy, I think, is when they become self-learning, when you get enough data into it and it starts to feed back off the outcomes. I think that's where things will get really interesting. Then it does become better than the people that built it. I think that's where some of this fear of AI comes, is when they start to be, start to make their own decisions and start to learn. Clinician time used, right? So we got clinicians out, patient outcomes, average number of appointments, basic things, calculation, consultant cost assessment calculated based on charge and number of patient appointments, and submetric of accuracy, number of appointments made with surgical practices. So again, they want us to clear a lot of these out, as they do here. How can we free up our surgeons and get them the people that they can really help? And so these were the metrics they held me accountable for. I believe it's still going on there right now, the study. And they would put me through the model accuracy and validation. And so again, like I say, this is like not just me. I mean, it was Neil Shepard and I came up with it in a martini bar, but I mean, it requires all of these builders and programmers and the physicians to help us guide this, where they should go. And so, yeah, I mean, it's really exciting and how, we can use this. I think that what's even more exciting, I'm the CPT representative for audiology for ASHA. And there are now CPT codes that are, as you know, with the AMA, that are AI. They have a whole AI team formed, and they have different levels of AI. And so this is, AI, again, it's sort of like a nebulous sort of term, but there will be codes, and then how do you build these codes? And so this is coming in every discipline. And so I think it'll be the next 10 years, we're probably going to be building AI codes and AI devices. Like I say, the AMA and CPT and RUC are very interested in, how do we deal with this, and as it becomes more and more, pervasive throughout healthcare. So.